Thank you.
Our next speaker is Dr. Jennifer Robinson from the University of Iowa, who will be giving the ODYSSEY Long Term Safety and Tolerability results. Dr. Robinson.
Alirocumab. Got it.
Hello, thank you for the opportunity to present the data from the ODYSSEY Long Term trial on behalf of my colleagues. Now, the design of ODYSSEY Long Term is a little bit different than what you saw for the previous two trials. Similar patient populations, however, it included people with either heterozygous FH or high CVD risk, so people who could have been in either of the previous two studies with LDLs over 70 on maximally tolerated statin therapy. About 44% were on a high-intensity statin. People were randomized to either alirocumab, 150 milligrams every 2 weeks. So there was none of this up-titration. Everybody went directly to 150 milligrams, or placebo. Again, it was a pre-specified analysis. Everyone has completed 52 weeks, and the average follow-up is 65 weeks in the data reported today. The primary outcome was percent reduction in LDL of 62% compared to placebo. And that was from a baseline LDL of about 122. 79% achieved an LDL less than 70. And again, per the previous question, depending if people had cardiovascular disease or not, if they had cardiovascular disease less than 70, if they didn't, less than 100. And you can see similar rates of achievement of those goals as well. Safety was quite similar across the two treatment groups. Again, there was a little bit fewer all cardiovascular events. And you can see numerically more neurocognitive disorders, but you can also reflect back on the previous two studies where there was an imbalance the opposite direction. So looking at the ODYSSEY program as a whole, there's no imbalance in neurocognitive events between alirocumab and placebo. So there does not appear to be a signal in that regard from this or other trials. And this is what I think is the most important piece of information to present in regard to the long-term study. The previous analyses were all pre-specified, but as part of the analysis of the safety, there was an examination of the pre-specified endpoint being used in the ongoing ODYSSEY outcome study. So this is an 18,000-person cardiovascular outcomes trial, which is using the combined endpoint of coronary death, non-fatal MI, fatal and non-fatal ischemic stroke, and unstable angina requiring hospitalization. So using this pre-specified endpoint from the cardiovascular outcomes trial, when examined in a post hoc analysis in the long-term trial, you can see there's quite a significant reduction in cardiovascular events with alirocumab. The gold line here represents the number of events with alirocumab. The blue line for placebo. There's a 54% reduction in the relative risk of cardiovascular events with 65 weeks of treatment in this trial of 2,300 patients. So in conclusion, long-term is the largest and longest study of PCSK9 inhibitor to date, with over 1,900 patient years of exposure. There was a large 62% reduction in LDL levels compared to placebo. 79% achieved an LDL less than 70 or 1.8 millimoles, with similar rates of adverse events compared to placebo. It was quite well tolerated. And this is the first trial with the PCSK9 inhibitors to suggest that there will be a significant reduction in cardiovascular events when it is added to maximized statin therapy.
Well, thank you, Dr. Robinson. This paper's open for discussion.
Yes, could you give the absolute number of events, and also could you say whether this occurred more in the heterozygous, the heterozygote population or in the clinical population?
So I think the rate was 1.4% in the alirocumab group and 3% in the placebo group for this post hoc analysis, if that was your question. We haven't done any subgroup analyses. We have not looked at, by baseline LDL, et cetera. Those analyses will be presented at American Heart Association in November, as well as analyses looking at safety and efficacy with LDLs less than 25 and less than 15.
Michael Reardon. Give him the microphone up here, please.
Hi, Michael Reardon again. Just based on sort of, the guidelines that you authored recently, could it be argued that these patients were undertreated? I mean, only 44% were on a high-dose statin.
Well, again, ideally they were supposed to be on the maximally tolerated dose of statin. So some of the countries, didn't have high-intensity statins approved for the patients, but the rest of them had a documented reason for not being on a high-intensity statin. So I think this is actually pretty representative of practice, because ideally we want people on high-intensity statins who have cardiovascular disease, but obviously not everybody can tolerate it or is a candidate due to safety reasons for a high-intensity statin. And then moderate-intensity statins would be appropriate in those situations. So I think, yes, I mean, the baseline LDL was 122, so it is higher than we would have it, in a pure CV population like in combo 2 because of the heterozygous FH people that were included. But yes, it's still a dramatic, I didn't present the achieved LDL, but it was about 50 and then we'll talk about that some more in the subsequent presentation.
Lynn?
Hi, Lynn Peterson with Trends in Medicine. So I'd like to ask you, and Dr. Cannon, please, and Dr. Harold, all three of you. So if this drug were approved today, what % of your patients would you expect would be taking this? Is this a niche product, for, 5% of patients? Or is this something we're going to start seeing in a year or something? Would half the patients be on it?
Right. So the companies are planning to file for an LDL lowering indication, so a surrogate endpoint. And there is unmet need. Certainly people with familial hypercholesterolemia are certainly candidates today. And certainly people with statin intolerance would be candidates to achieve, a 50% or greater LDL lowering. I think, and what this data tells us is we're on the right track, right? I mean, it's not the definitive evidence. We need the outcomes trials to validate this data and also to establish the long-term safety of these drugs added to statins. So we still need more data. We can't approve it and give it to everybody routinely after a cardiovascular event. That's not what this data shows, but at least it shows that we're on the right track with using PCSK9 inhibitors, in this case alirocumab, to further reduce cardiovascular events in people receiving maximal statin therapy.
We'll take one more question.
My question is, the answer to my question?
Yes, I think there is immediate genetic hypercholesterolemia and statin intolerance.
So what,
today.
Is this 5% of patients? Is this half? I'm trying to understand the...
Well, the genetic hypercholesterolemia is fairly common, and then probably statin intolerance. So I'd say, 15% probably are candidates in terms of immediate unmet need.
Let Dr. Cannon answer.
I think this level of LDL lowering is needed very broadly, and so we're cognizant of balancing cost issues, but to get everyone down to a level of 50 would be pretty good and broadly applicable to high-risk patients, high cholesterol, statin intolerance. So millions of patients this is applicable to.
But we're not quite there yet. We need some more outcomes data.
I can comment afterwards. Last question.
Yes. How are you defining statin intolerance?
Well, this is in debate with the FDA. What is the exact definition? But in general, people who can't tolerate at least one recommended dose of a moderate or high intensity statin.
is that based on the fact that they wake up in the morning and have aches and pains, or do you do further emphasis on that? You know, if you tell a person that you're likely to feel muscle pain, and after, as one of the side effects of this drug, and then they wake up sore, then they're going to
well,
say,
you're talking about statins, so
yeah.
this is a separate
Yeah.
agent, but I think we dealt with that in the guidelines. I think we have to be very sensitive that people have lots of aches and pains, and that you need to establish with repeated challenge to make sure they are truly statin intolerant, because statins are so effective. We want to be sure people can take them.
Well, thank you, Dr.
Thank you.